Next up, we're going to talk about some electrocardiography. Again, I know most people are here for the skiing, and I don't want to burden your minds with too much when skiing is probably the main thing that everybody is here for. So I'm going to try to limit the take-home here to really just two simple things once again. And I find that as I get older in emergency medicine, I learn an awful lot by my own mistakes. And so I'm going to show you a couple of topics that I've unfortunately learned from my own mistakes and colleagues' mistakes, and also some mistakes that result in med mal. And again, two very simple electrocardiography points. Because I know maybe the ski slopes and the snow are on your mind, I'm just going to start with the take-home points. All right? So the next slide is my take-home points, and if you get these take-home points, you're welcome to head right on out. So in conclusion, number one, not all ST elevation is STEMI. And number two, pay attention to axis. All right? It's one of those parts of the interpretation that I think people really don't pay attention to, but in this talk, I'm going to show you how sometimes axis, and in particular right axis deviation, can really, really be helpful. And missing this has resulted in a lot of miscues along the way. So let's start once again with the case. It's an 80-year-old brought in by ambulance for chest pain and shortness of breath. On exam, he looks pretty sick. He's tachycardic to tachypneic. Blood pressure is 105/50, which is probably a little bit low for this patient. Pulse ox is 95%, and here's your 12-lead ECG. All right, this was the ECG that the paramedics sent on over. There's some nice ST elevation in V1, V2, maybe V3, a little bit of elevation in lead 3 as well. And you'll notice the axis up there, all right? And we'll come back to this in just a moment. What are the things that give you rightward axis? Please don't memorize this, all right? This is the internal medicine differential for rightward axis, all right? There's a lot of different things that produce rightward axis. Most of these give you a chronic rightward axis. In emergency medicine, we're more concerned about what kind of things give you an acute or new rightward axis, and I've highlighted the three things that, at least I teach my residents. When you see what looks like a new rightward axis on the 12 lead, there's really four things that you've always got to consider, all right? Number one, hyperkalemia, which can do anything to the 12 lead. I oftentimes refer to hyperkalemia as the great imitator or the syphilis of electrocardiography, right? It'll produce anything, including axis changes. Acute PE, not the little PEs that we all got traveling here, but I mean the big PEs, the big PEs that produce hemodynamic instability and produce patients that look relatively sick. Sodium channel blocking drugs, for example, tricyclic overdose. Hopefully you'll pick that up with the history. And then perhaps one of the more common ones, misplaced leads, all right? When people screw up the lead placement. Those are the four things that you've got to always consider, especially, I don't know if there's any residents here, but you've got your in-service coming up later this week, so probably no residents here. But on the board exam, certainly when you see that rightward axis, these are the things you've got to think about, probably forgetting misplaced leads, because I don't think they put that on the board exam. But in terms of the things that can also produce ST elevation and mimic STEMI, we'll narrow this down to largely PE and hyperkalemia. Tricyclics can produce ST elevation primarily in AVR, but in other leads, I've never seen that before, which doesn't mean it doesn't happen, but I think it would be enormously rare. So when you see what looks like a STEMI, and here's the whole take-home point from the first half of this lecture. When you see what looks like a STEMI, but there's a rightward axis, think PE and think hyperkalemia. And make sure you think about those and at least rule them out in whatever way you think is appropriate. All right? Because a lot of these get misdiagnosed. All right. Because a lot of these will mistakenly make us think about STEMI. So here's the echo. I'm sure most of the people that are great with echo are going to put a probe right on the chest, and what's the diagnosis now? There's a big distended right ventricle, and I'm helping you out. It's also in diastole, and there's some arrows pushing inwards on the septum. This is a massive PE. All right? And that's exactly what this turned out to be. This was not a STEMI. This was a massive STEMI, and actually, or a massive PE. And actually, this ECG shows you what I would consider almost all of the very classic findings on ECG in PE, which we'll go through in just a bit. Now, what we've all learned about PE ECGs is there's this classic S1, Q3, T3, and I always joke that the word classic is derived from the Latin word, which literally translates to 15%. Right now, it's not true. But whenever you hear anything in medicine as classic, it means 15%. S1, Q3, T3, 15%. The classic triad of AAA, pulsatile abdominal mass, hypotension, and abdominal back pain, 15%. Right? Many, many other things, 15%. Rightward axis. I think rightward axis is the most important part of this S1, Q3, T3. It's the big S wave in lead 1. Now, I'm not talking about S waves. I'm talking about big S waves. S waves that approach the size of the R wave or are bigger than the R wave. Rightward axis. You've got to think about PE here. Sinus tachycardia is very common in large PEs. As an aside, if you take all comers with PE, in the largest international studies, the EuroPED and PIOPED studies, how common was tachycardia in all comers with PE? 30 to 50%. It is not something that is in the majority of PEs. But when you look at large PEs, hemodynamically destabilizing PEs is probably about 75 or 80%. And the tall R wave in V1. I'm going to also add, there's more recent literature that's talked a lot about T wave inversions, and hopefully this message has gotten out there that I'm not going to get into detail on, but just to show you a few cases, T wave inversions are very, very common in large PE and are beginning to become one of those things that I think we should all be learning about. In fact, if you go back 30, 40 years, back when Marriott used to teach electrocardiography, he used to talk about this simultaneous T-wave inversions in the inferior plus the anteroseptal leads is enormously specific for PE. In fact, there was one study that was published in the cardiology literature that said when you see T-wave inversions in the anteroseptal plus inferior leads, it was 99% likely to be PE. So very, very common. Here's just some examples. Take a look. T-wave inversions in the inferior and anteroseptal leads. T-wave inversions in the inferior and anteroseptal leads. T-wave inversions in the inferior and anteroseptal leads, enormously likely to be PE. And this is a great case that had a lot of people fooled. Take a look. Everyone's focusing, I'm sure, on the little intermittent run of VTach, non-sustained ventricular tachycardia, but what was not noticed was T-wave inversions in the inferior 3 in AVF and the anteroseptal leads. This was a big PE that was producing the intermittent runs of VTach. Lidocaine was given, got rid of the PVCs, not the PE though, and fortunately they ended up making the diagnosis here. So please bear in mind, as an aside, T-wave inversions are very common in large cases of PE. More recent literature has talked about a few other findings as well, and I'm just going to move quickly through the references here. What recent literature has shown us is that there are certain things that predict adverse outcomes, an increased risk for morbidity and mortality in the presence of PE. T-wave inversions, they talked about ST elevation and depression, especially in the rightward-ish leads. Remember, V1 is kind of a rightward lead. V2 is almost trying to be right side. Lead 3 looks a little bit more at the right side. AVR also. So ST elevation in these leads in particular is common, relatively common, in large PEs and a predictor of adverse outcome. And then rightward axis, all right? And here's the key thing. Acute STEMIs very, very rarely ever produce rightward axis. You generally will not see a new rightward axis in an acute STEMI. Old STEMIs can produce a rightward axis if there's giant Q waves, but in a fresh STEMI, it's very unlikely you're going to see a rightward axis. So when you see ST elevation with the rightward axis, think PE and hyperkalemia. So going back to this case again, what you see up here, you see sinus tach. You see, in this case, there's a large S wave. S1, Q3, T3, but more importantly, I just want to focus the rightward axis in combination with ST elevation in V1, V2, AVR, and lead 3. That's about as classic as you're going to get in terms of the type of ST elevation that PE produces. Are you going to look at this and call it a STEMI? Very unlikely with a rightward axis. Here's another example. ST elevation, V1, V2, AVR, not much in lead 3, and a rightward-ish axis. That should point you towards calling it, again, not a STEMI, but a PE. Here's another beautiful case. ST elevation, V1, a bit in V2, trying to be in lead 3 also, but AVR and a rightward axis. This is not a STEMI. STEMIs don't tend to produce new rightward axis. When you see ST elevation, think about PE and hyperkalemia. So just a quick summary here. What are the things to be looking for on the 12 lead of a patient with a PE? Everybody knows about sinus tach. Everybody knows that you can get some supraventricular and ventricular arrhythmias. Everybody knows about the S1Q3T3, which really I would focus your attention on the rightward axis. But also please remember that PE can produce ST changes, including ST elevation that can mimic an acute STEMI, but if you see that rightward axis, don't think STEMI number 1. I would think PE, hyperkalemia, PE, hyperkalemia, PE, hyperkalemia, and maybe number 7 is STEMI, all right? So think PE and hyperkalemia when you see that rightward axis, in particular in the rightwardish leads, V1, V2, AVR, and lead 3. Those are the leads in which PE is most likely going to produce the ST segment elevation, all right? So, questions about that so far? Everyone okay with that? All right, some interesting signs here. I thought this word, case number 2. This was sent to me by a physician out in San Francisco, Dr. John Kenyon. So if he's out there listening, thanks for sharing this. So patient, late 40s, 47, 48-year-old, came in complaining of nausea, vomiting for 12 hours, 1 hour of burning epigastric pain, history of diabetes, and there's the 12-lead ECG. Now, if this person shows up in your practice, what are you thinking? Thinking about activating the cath lab, big time ST elevation in those rightwardish leads. Once again, V1, V2, AVR, and while many of his colleagues were thinking activate the cath lab, he noticed that there also happened to be some mild peaking of the T waves and a rightward axis, which is not typical for a STEMI. So instead of activating the cath lab, what he decided to do was just try some calcium and bicarb. He gave 2 amps of calcium, 2 amps of bicarb. What happens if you're wrong? What happens if the patient is having a STEMI and you give 2 amps of bicarb to a STEMI patient? What happens to him? Nothing, right? If I gave everybody in this room 2 amps of rapid IV push bicarb, push, what happens to you? Nothing. Your soda will taste kind of funny. Your beer will taste kind of funny for a little while, 15, 20 minutes, and then it's metabolized and gone. What happens if you give 2 amps of calcium to somebody who doesn't have hyperkalemia? What happens? Their bones get stronger. Nothing happens, right? It's great. It's no harm. There's no harm from doing that. And you just might save life. So that's what he did. Turned out the patient's potassium was 7.3, but before he knew the potassium, he gave a couple amps of bicarb. Take a look. Bicarb, calcium, QRS narrows, STs come right back down, no cath lab activation. This is nothing more than hyperkalemia. This is not something I ever learned about hyperkalemia. What I learned about hyperkalemia was peak T waves and wide QRS. And I remember learning that the P wave gets smaller and goes away. So sometimes it can mimic VTAC because you've got a wide QRS and no P waves. And I also learned about the sine wave, right? Everybody learns about the sine wave, or I guess if you're from the southern hemisphere, you call it a cosine wave, I don't know. But everybody learns about that. But ST segment changes, nobody taught me about that. Nobody ever taught me about that. In fact, I'll bet you if you look in Tintinelli and Rosen and many of the major internal medicine books, there's nothing about it in there. If you look in the electrocardiography books, it's in there, all right? ST elevation. So once again, here's our differential for things that produce rightward axis with ST elevation. I highlight sodium channel blocking drugs, but again, I'm emphasizing I've only ever seen sodium channel blocking drugs produce ST elevation in AVR. So in my practice, what I teach, when you see ST elevation in combination with the rightward axis, the first, second, and third thing you're thinking of is PE and hyperkalemia. All right, let me show you just a handful of more cases of hyperkalemia, just to really hammer this home. Some of these are going to jump out at you and be really, really obvious. By the way, take a look at the computer interpretation at the top. It's calling this a STEMI. So much for computer interpretations, right? Nobody would miss this. There's ST elevation V1, V2 in multiple leads, maybe 3, and there's a rightward axis as well. Take a look at this one. This was initially diagnosed as sinus rhythm with a massive anterior STEMI by the computer and the physician, because it looks like there's sinus rhythm, P waves, with huge ST segment elevation, V1 and V2, but there's rightward axis. STEMIs don't give you rightward axis, except very, very rarely. I don't want to say anything's 100% in medicine, but it's enormously uncommon. Here's another one that was initially misdiagnosed. Fortunately, the last case and this case ended up being diagnosed properly, all right? This case had cath lab activation, And cardiology took a look at it and says, no, this is not a STEMI, it's rightward axis. They said, this is rightward axis, STEMIs don't do this. Just try some calcium bicarb. So before the patient went to the cath lab, calcium bicarb, boom, patient went right back to sinus, all right? Here's another one. This was properly diagnosed, but the computer called this anterior wall STEMI because of the ST segment elevation in the rightwardish leads, V1, V2, V3 also, AVR, maybe lead 3, rightward axis. You don't get rightward axis with an acute STEMI. All right, here's another one. I showed this to you just a little while ago. The computer really screwed this one up by double counting the rate and calling it an anterior wall STEMI, ST elevation V1, V2, AVR, and rightward axis. Here's another one. This patient was transferred from a community hospital to University of Maryland to the cath lab for what was thought to be a STEMI. It was thought to be an anterior STEMI because the computer called it an anterior wall STEMI, and the physician transferred the patient over with the diagnosis of anterior wall STEMI. The patient went to the cath lab. Cardiology took a look at the 12-lead EKG. ST elevation V1, V2, AVR, rightward axis. So before giving any heparin, patient actually, I think, had already gotten Plavix, which doesn't treat hyperkalemia. They gave calcium and they gave bicarb, bam. Problem solved, patient got admitted to medicine instead. Nothing more than hyperkalemia. Here's a couple of other nice cases. Again, the computer's calling this an acute anterior wall STEMI, ST elevation V1, V2, AVR, and a rightward axis. That's hyperkalemia. Now here's another one. In this patient, there's no rightward axis to help you out, but again, ST elevation, the rightwardish leads V1, V2, AVR, and hopefully you notice that there's peaking of the T waves. I've shown this to at least a dozen people. Nobody, well, I shouldn't say nobody, probably only about half the people even notice the peak T waves because they're so focused on the ST segments. All right. And here's another one. This was sent to me very recently. Huge ST elevation, V1, V2, AVR, the rightwardish leads, no axis change to help you out. So the axis isn't always there, but when you see that ST elevation, the rightwardish leads, at least keep your PE and your hyperkalemia in the differential. Think about it, all right? And then maybe you notice, looking a little bit more closely, yeah, those kind of look a little peaked, don't they? All right? That's nothing more than simply hyperkalemia. So key take-home points from this second case. Again, beware hyperkalemia. Hyperkalemia does a lot of different things. Everybody's learned about the peak T waves, the wide QRS. The PR gets prolonged and then goes away, so you can get a wide complex rhythm with no P wave, so it can start to mimic slow VTAC, all right, which is a term I don't like because I don't like VTAC even in the phrase here. But whenever you see a wide complex rhythm and the rate's relatively slow, don't call it VTAC. Think about hyperkalemia. Again, it can give you tachycardia, bradycardia, strange AV blocks, and again, something that I think most of us never learned in med school or residency, it can produce pseudo-ACS. It can give you T-wave inversions and more commonly ST segment elevation, typically in the rightwardish leads, and oftentimes ST segment depression as well. All right. So take-home points. Beware hyperkalemia again in those rightish leads. V1, maybe V2, and AVR in particular. So summarizing things up, quick take-home points. Remember, when you see ST elevation, especially in the rightward side leads, with the right axis, don't think STEMI up front. Think about the possibility of PE. Think about your hyperkalemia, because they are notorious for mimicking these type of things. STEMIs in general don't produce a new rightward axis. So if somebody's coming in acutely symptomatic and you see a big rightward axis there, it's very, very unlikely to be a STEMI. Very unlikely to be a STEMI, all right?